Well, hello, everybody. So my name is Luka Vlahovic. I'm one of the MS neurologists at Providence MS Center, and we're going to talk today about basics of multiple sclerosis. And so, in particular, what is MS? What are the most typical or common symptoms? What are the subtypes of multiple sclerosis? Some general concepts how to diagnose this disease, also how to approach in terms of treatments from both standpoints, immune baseline therapy as well as symptomatic treatments. We'll touch upon MS wellness and towards the end also about some updates and what is on the horizon in the field. Uh, so in general, kind of what is MS? So it is a lifelong disease that predominantly affects brain, spinal cord, and optic nerves. It is also important to make distinction to some other autoimmune diseases, in particular rheumatological diseases that can affect multiple organ systems. So this is really affecting only central nervous system. It is also important to mention that the majority of patients with MS do not become severely disabled, although this disease is very variable, so its clinical presentation can vary from very mild to pretty severe presentation in general. This disease has a pretty complex pathophysiology, and there are a few additional slides that will talk about that. It is considered to be autoimmune, although overall pathophysiology is more complicated than that. One of the central components of its disease process is demyelination, and which essentially is shown on the illustration on the right, where kind of these pipes in the middle or in the center represent axons that are projection from nerve cells, and they're usually lengthy, and they're the way how two nerve cells communicate with each other, or nerve with muscles or other affected organs. And then these kind of yellow sheets around it actually represent myelin, which has multiple purposes. The main one being protective and also allowing very fast propagation of nerve impulses that actually allow our system to work properly and get all very complex function done. And you can see on the right here how it can be damaged, and if in case of inflammation that we see with multiple sclerosis. Okay, in terms of general pathophysiology, again, this is not complete pathophysiology shown here, but it is one of the important components, and I would say perhaps the most important one in terms of available disease-modifying therapy that targets this disease. So overall, we believe that disease starts in the periphery, so shown here with number one, so that the immune system gets activated. Still not completely clear why and how, but there are kind of various hypotheses. And then when T cells get activated, then go through bloodstream, they get availability to attach to the blood-brain barrier and actually penetrate through it, and then gets reactivated within the brain and spinal cord and cause damage. It is also important role of another lymphocyte here, and beyond T cell called B cells, and as I mentioned, kind of essentially all disease-modifying therapy targets some of these steps in the pathophysiology, although overall disease pathophysiology is more complex than that. In terms of prevalence of multiple sclerosis, one of the reasons, the very large epidemiological studies from somewhere around, I think, 2017 actually showed a notably higher prevalence than initially expected. What was previously reported, even from studies going back to 70s or 80s, was somewhere around 3 to 400,000 people who have MS and living in the United States. This most recent study from 2017, I believe, actually showed prevalence that comes close to 1 million. So it is more than doubled what was initially thought to be. And on the right side on this graph also shows changes throughout the years. So in 1970s, we thought, and these numbers are per 100,000 people. So in 70s, it was thought to be close to 60, and then gradually kind of going up with these most recent studies showing somewhere around 360 people per 100,000, one who have MS. It is not quite clear why this, this increase happened, whether we diagnose this disease better, whether it could be through increase in prevalence in disease itself. Could this be some access to kind of more modern technology that we're not able in 70s or 80s, or effects on immigration? It's hard to say, but it's definitely much more prevalent than we thought it is. Now, in terms of who develops MS, so as I initially mentioned, that one of the main pathophysiological concepts is that this is autoimmune disease. So it's similar to other autoimmune diseases. It's more common to be diagnosed in younger or young to middle-aged people. Some average age or median age is around 29, 30 years of age, where most people get diagnosed in 20s and 30s. Although it is also important to mention that approximately about 5% or less, it can be diagnosed in pediatric population, mainly in adolescent kids or even before that. And in less than 5%, it can be diagnosed kind of at later onset, usually after the age of 55 or 60. It is more common in females with a ratio 2 to 3 per 1. Also, Caucasians are most likely to have MS. And in terms of geographic distribution, there is increased prevalence of this disease as going further from the equator. And I believe next slide shows that. So let me just show. There are different colors that codes for different prevalences. So for example, in this particular picture, so red color would indicate the prevalence of above 100 per 100,000 people, while for example, this blue color represent 5 to 20, so much lower prevalence. And as you can see from this picture, it is much more prevalent in US, especially northern part of US, Canada, and some part of Central and Northern Europe than it is in Africa or South America. Again, following that gradient as going further from equator, its disease is more prevalent. Now, in terms of potential triggers for MS, there are different theories and different associations that were found. We still don't know exactly, so there's no one specific kind of causative agent found. There are different theories in terms of, some of them are shown here. The genetic predisposition is important. Definitely, although it is still thought that environmental factors are perhaps a little bit more important in exposing the disease overall. Infectious agents are important factors, especially viruses such as EBV and some other viruses that were postulated to be associated with MS. There are also another factors that we will also mention further in this presentation, such as vitamin D levels, smoking. There are also some newer studies in recent years looking for association between biofilm or bacterial and GI and potential association with MS. But again, all of those are still more speculative and not definitively confirmed. Now, kind of a little bit more about genetics. So again, it's not directly inherited. There is International MS Genetic Consortium that identified more than 200 variations in human genome. And in terms of some numbers, just to illustrate genetic predisposition, so if one parent has MS, someone risks to get MS is 1 in 67, as opposed to 1 in 330 in general population. If one sibling has an MS, then that risk increases to 1 in 37. Also, some data showed that in monozygotic twins, so people with identical genetic material, that if one sibling has MS, the chance that another one will be about 25%. So there is, as I previously mentioned, there is definitely some genetic component, but it still seems that environmental factors are very important in terms of who will ultimately develop disease. I alluded this previously about viruses, and especially Epstein-Barr virus. It is very interesting that almost anybody who has MS will had exposure to this virus previously. The bigger problem here is because general prevalence even beyond MS is high. So we're really dealing with, I mean, almost 100% of prior exposure versus very high, like 90% or above in general population. So that's why it's difficult to kind of distinct if this virus can be causative beyond this well-known association. And also current or previous smokers where high levels of EBV were more likely to develop MS. Vitamin D as an important factor to consider. Multiple studies suggest the protective effect of it. Although the studies are a little bit more mixed once somebody has MS, but I would say still the common practice and standard of practice is, these days is to recommend regular supplementation of vitamin D. And it is important to follow up on these levels, as it is also important to avoid toxicity, although it has pretty wide therapeutic window, so it's really doses needs to be higher to reach those levels. Now, moving to the symptoms of this disease, they're really very variable, and given complexity and variability of this disease, and the fact that it can really affect any part of central nervous system, symptoms will essentially be related to the anatomical location. So, for example, some of these, if optic nerves are affected, somebody can have optic neuritis, which usually manifests with a vision loss, in particular, difficulties with reading, seeing colors. On the other hand, if long-term pathways that convey motor and sensory information are involved, sensory symptoms can be present, such as numbness, tingling, pins and needles, weakness, or stiffness, again, affecting usually part of the body. Consequently, balance can be affected, or gait and walking. If pathways that control sphincters in the bladder and bowel are affected, also some pretty common symptoms in MS could be urinary or bowel symptoms, mainly urgency or difficulties to control, or even sometimes to the opposite, retention. Then fatigue, that is very prominent symptom and difficult to measure. As well as cognitive changes as well that are not specifically mentioned here. So those are all symptoms, and this is not kind of exhausting list, but as an illustration of some of them that are really typical in MS. Now, some of these can be fluctuating and can get worse if somebody is sick or if it's hot outside. What kind of constitutes relapse, and it is the hallmark of disease, is usually if these symptoms are new, if they last at least 24 hours, but usually longer, days to weeks, and again, if they're not provoked or precipitated by some other identifiable cause. In terms of courses of MS, so this is some kind of old-fashioned classification that we still use these days, especially in clinical trials. So as I just mentioned, kind of relapse is a hallmark, so meaning focal neurological deficits that last usually days to weeks with improvement or even sometimes complete recovery, especially initially into disease course. And the most typical pattern seen would be relapsing remitting disease that happens in about 85%. And this is what's depicted here. So, so on x-axis would be time, on y-axis it will be neurological symptoms or deficits. So we can see that these relapse occur, reaches plateau, and then gradually improves over time, either to a complete normal or leaving some residual deficits behind. Now, the second course would be secondary progressive. So, and a secondary, so meaning it always follows relapsing course. So the certain number of people who have relapsing remitting multiple sclerosis will convert to this type. So, and as you can see here, especially in this kind of second part of the slide, so really these distinct relapses become much less prominent or non-present at all, but rather there is gradual worsening of baseline symptoms. And then primary progressive MS that happens in the remaining or occur in the remaining 10 to 15% of people really won't have that relapse as a hallmark of disease, as I mentioned, as a main hallmark of disease, but rather gradually worsening course since the beginning. So usually symptoms that affect especially lower extremities with some weakness, stiffness, walking difficulties, bladder bowels, the difficulties, and then developing rather over months and years. This is one kind of busy slide, but I really like it because I think it's kind of shows complexity of MS, and some of these will be repetitive. Some of this will be kind of put into the context of various courses of MS. So again, x-axis is one where age is depicted. So here we can see 30, 40, or going to 50. And then on y-axis, it's disability or clinical or neurological symptoms and deficits. So this dotted line here actually represent clinical threshold. So meaning that everything what is below that threshold is clinically silent. So someone wouldn't know that anything is going on because simply symptoms wouldn't be present, but still inflammatory activity can be occurring. And shown here, so these blue boxes are inflammatory relapses. So these first few here shown will not reach that threshold. So essentially, it will be clinically silent, and we really can find them usually based on MRI scan. So so sometimes we can when somebody comes with a kind of first clinical event or first relapse that's called clinically isolated syndrome, we can actually see multiple lesions, and then these other lesions that do not correspond with an active relapse at that time would represent these kind of subclinical relapses that happened sometime in the past. And then, so not everybody who develops clinically isolated syndrome will end up having multiple sclerosis, but that's the kind of the first relapse, and we call that as a this entity, CIS, or clinically isolated syndrome, if full criteria of MS cannot be met at that point. Then further natural disease process again is characterized by these relapses. Some of them can be again subclinical. Some of them will reach threshold and present as a new kind of persistent symptoms over days and weeks and affecting part of the body usually. And then over the years, approximately in about 50%, in 10 years, and perhaps that number is higher if followed longer, of people will convert to a secondary progressive course that I just mentioned on the previous slide. And on the other hand, so this kind of red dotted line showed some tissue loss and axonal loss. And this blue line actually here represents primary progressive MS, so where there are no really these distinct relapses, but rather from the point when it becomes clinically apparent, slowly getting worse. And then usually that primary progressive MS starts to occur later. So if in relapsing course it's 20s and 30s, in primary progressive it's more common to see in late 30s and rather 40s, if not 50s. Now, this is also a nice picture to show, because a lot of things in MS kind of occurs below the surface. It's not visible or easily measurable. And this is one of the examples. So that what we see on the top is clinical relapses, but actually some of these subclinical relapses or tissue loss, or even if we extend this to some of the symptoms such as fatigue or cognitive changes that are really non-measurable, they all really happen kind of below the surface, and it's not always easy to detect them. Now, moving to the diagnosis of this disease. So it is there are 2017 McDonald criteria that are, pretty clear, but also they just give some general framework. So in certain situations, kind of we need to do much more detailed work, especially if diagnostic criteria are not easily met. It is also important to mention that there are new diagnostic criteria that are coming. They're still not finalized, but perhaps will be at some point next year. But in general, kind of in a big picture, when we're diagnosing MS, so it's important to take history. Again, looking for the specific symptomatology that would be compatible with relapses that I previously mentioned, and usually trying to find the corresponding examination findings that will correspond with those relapses in the past. And then MRI is really extremely important these days, and almost it will be impossible. Not completely, but in vast majority of cases to diagnose MS without having MRI. So, these would be really the most important. So clinical history, examination, and MRI. And then what specifically we're looking for is what's called dissemination in time and space. So if it's possible to fulfill that there are more than one characteristic area is involved in a central nervous system, so at two different time points. And these criteria that kind of are evolving, that I mentioned that new are coming, essentially try to help us facilitate diagnosing that as early as possible in order to proceed with appropriate treatment. These another option mentioned here. So laboratory tests, spinal fluid, evoked potential, those are all tests that can be done, but not always necessary to be done. So spinal fluid is a part of diagnostic criteria that sometimes we we use and can be very helpful, especially if in doubt or clinical presentation is not clear. Laboratory tests use mainly blood tests to rule out some MS mimics when looking to some other diseases and entities that can present similarly, that are maybe more systemic, but that can affect central nervous system as a part of systemic presentation. And evoke potential, or I could add optical coherence tomography, that is another test that can help us to look more into optic pathways and optic nerves that can be frequently affected in MS, to further assess if, especially kind of when we need to fulfill those criteria for dissemination in space and time, to make sure to meet them if needed to accurately diagnose MS. Now, as I mentioned, MRIs is extremely important. And so there are many sequences that we use in order to visualize and better interpret various lesions and spots on MRI. Particular ones are gadolinium T1 with the gadolinium contrast, where we're looking for specifically their active lesions in case when there is acute inflammation, blood-brain barrier will be disrupted, and then gadolinium contrast that's administered intravenously will leak into the brain tissue. So we can see, because these areas will be lightened, and we can see them as bright areas on MRI, specifically on this sequence. It is expected that this type of what we call enhancements on MRI will resolve within a few weeks, usually not more than 2 months. And then after that initial phase, we can also track lesions on another sequences, especially on T1 based sequences. One that we particularly use is called FLAIR. And then we can actually on that one see cumulative kind of lesion load over the years that can help us also stage disease and better understand the severity of the disease. And those are some pictures just to have an idea how they look like. So this will be T1 with a contrast. So those are just as in general orientation. So those are ventricles. Each of us has them. And then in normal T1 should be all darker with this kind of gray and less gray areas. So all these bright spots essentially that we can see, it's probably on this specific cut, we can see as many as 7 or 8 or so represent area of active inflammation, and in this case indicate a very active disease process. On the other hand, so this is another sequencer T2. So this is one that I mentioned where we can see cumulative lesion load over time, and in particular, some of these lesions that tend to be like elongated, ovoid, under 90 degrees compared to the ventricles are kind of typical ones, or one like this one that is almost like touching the surface of the brain. So it's also important to look for specifically morphology and location of these lesions when assessing MS, because we'll see there are also some other conditions that can present similarly, but due to another reasons beyond MS. This is the same thing, just from different angles. So this is a sagittal or vertical cut. So those are these typical lesions that usually follow kind of veins, and that's why they have these kind of what's called in the medical textbook like finger-like projections, and almost arising from these ventricles. And here is another typical area. This is the back of the brain. So we can see eyes here, and nose, and a little bit of the ears. So it's essentially these kind of bright areas are ones where we can identify lesions. And again, this will be one of the typical location for lesions in multiple sclerosis. And the last area that is also typical in MS would be spinal cord. So this is a vertical cut looking aside. So here's the spinal bones. This will be the chin here. the back, and then here, for example, R1, and there's another one, perhaps the third one here, a little bit subtle one. So these bright areas within the spinal cord are actually where inflammation occurred at some point in the past. Now, this is also important to know because not really all white matter spots are due to MS. So that's when I mentioned that it is really important to look at morphology, to look at kind of specific, how do they appear, if they're very small or rounded, or if they're very deep, if they're elongated. And because many other things, and pretty common actually, things in general population can present similarly. In particular, age-related small vessel disease or microvascular changes that can be seen in the setting of vascular risk factors. So high blood pressure, high cholesterol, diabetes, smoking, migraines in particular can also cause some of these small spots. And also there's some other, again, this is not a completely exhausting list. So sometimes even we can see lesion that we postulated can be there even from kind of perinatal or in utero a time, but just stay there for a long time and being asymptomatic. And then if somebody did not have MRI previously in life, simply they would be unrecognized. So it's just really important to kind of keep all of this in mind to when approaching diagnosis of MS, to be sure to rule out some of the diseases and entities that can present very similarly. Now moving to the treatment portion. So there are kind of few concepts how we can treat MS. So here, specifically on this slide, what was depicted. So first on the left would be how to treat acute relapses. And then on the right side would be more for general symptomatic treatments. And then we will discuss on the next slide immunomodulatory treatment. So in general, for relapses, the mainstay of treatment is to use IV steroids, 3 to 5 days of high dose, either a methylprednisolone intravenously, or there is also equivalent oral form that is a little bit cumbersome because it requires 25 tablets of 50 milligrams of prednisone a day, although for a short period of time, 3 to 5 days, depending on the severity. The whole purpose of administering IV steroids is to hasten recovery, to expedite healing of blood-brain barrier that get disrupted, and help symptoms improve faster. They usually really won't have long-term effect, but can be very helpful in that short time frame after inflammation happens. Sometimes we can use, I didn't mention here, plasmapheresis, or even very rare circumstances, IVIG as an alternative options if really relapses are very severe. That definitely can happen, but are not very common in MS. In terms of the symptoms, again, this is kind of what was also discussed on some of the prior slides. So there are really many options that we can use to treat present symptoms. So, for example, for spasticity, there are a few spasmolytics that can be used beyond physical therapy that also can help with weakness, in addition with different assistive devices. For sensory disturbance, if there is nerve pain, there are different type of neuropathic pain medications. And then going down the list, so there again, different option for kind of different symptoms that we can use. Unfortunately, for cognitive impairment, there are no specific treatment option. It's really more working on a prevention and trying to control disease process to minimize impact on cognition. Now, so moving to disease-modifying therapies, so it's a different concept and different category. because this prior slide actually referred to medication used to treat current or present symptoms. Disease-modifying therapy are used prophylactically or as a prevention, so to be taken over a longer period of time, years and decades, to essentially minimize a risk of occurrence of new lesions. So to reduce relapses and to reduce subclinical relapses or new MRI changes, and then hopefully to also delay disease progression. In general, we all tend to start them as soon as we have a solid diagnosis of multiple sclerosis. This is also just to show how time frame is important, and the fact that we really want to start treatments as soon as possible. So this is, again, just as a general illustration, and as I mentioned, it's a very variable. It will be different in different people, but I mean, in general, if this is some general course that kind of tend to progress over time with these new relapses and new disease progression. So, for example, kind of if treatment is started kind of very early, then we're hoping to definitely achieve significant slowing down of disease progression, as shown in this kind of green part of this graph. And then if disease-modifying therapy started later on, there is still a value, but perhaps the peak core will be lower than if it started earlier. And then also, you know, if we go further down this kind of curve, again, as treatment is started later on, perhaps potential desirable or positive effect will be lower. So that's kind of why kind of whole emphasis is to start treatments as soon as we have solid diagnosis of MS. This is essentially this evolving MS treatment landscape. So this is since 1990s. So in mid 1990s were the first injectable medications that were available, and then really it is incredible how this field evolved and how we have many disease modifying options presently available. So here in yellow are injections, in gray are infusions, and blue are pills. So they're very different modes of administration. And I just added the ablitiximab or Briumvi as the last one, FDA approved last year. That is kind of also infusion. And we will kind of touch upon them on next few slides. So this is essentially platform therapy, especially designated on this slide. So Copaxone or glatiramer, and then different interferon preparations. So those would be medications that were approved in 1990s and early 2000s. Those are, in general, very safe medications given as subcutaneous or Avonex is an intramuscular injection with varying frequencies. So every other day, a few times a week, once a week. And as I mentioned, they're very safe, but as our field evolved, there are also some other medications that have become available over years, much more efficacious. So I would say that we use these medications much less frequently these days. Then moving to the category of oral medications. I mean, the list is pretty extensive, and it's easier really to kind of cluster or categorize them into different, almost like families of groups of medication based on their pharmacological targets. And so there are fumarates, a few of them. There is Aubagio. There is S1P that is again, pharmacological targets that these four medications specifically target. So all of these are various options that can be used, of kind of different efficacy. Perhaps these two, fumarates and Aubagio, are a little bit less efficacious than S1P agonist, and then cladribine is one that is considered to be of higher efficacy therapy and has a very kind of unusual dosing regimen, as there are two courses given 4 to 5 weeks apart on 2 subsequent years. So nothing essentially be taken between. And while these other medications are taken either daily or twice a day. And then each of them has some specific side effects. It needs to be, for example, Aubagio. It's contraindicated in people who are planning to have children. These medications, S1P, should be avoided in a situation of diabetes or cardiovascular risk factors. So yeah, they're kind of it's important to consider all of those when assessing what will be the most appropriate disease for a specific disease modifying option for a specific patient. Then moving to Kesimpta. So this is one of the more efficacious treatment approved in the last few years. That is injection, and as most of other will be infusions. So you will see on the next slide. So this is monthly injection, and works very similar as in these two medications, ocrelizumab and Briumvi. Again, talking about kind of family of medications because they have the same mechanism of effect essentially. So they're of very, very similar efficacy. The difference is that those two are infusions that are given or administered every 6 months, with the exception of the first dose, and Kesimpta is one that is administered as an injection. And then the remaining two are Tysabri and Lemtrada, that perhaps are a little bit used a little bit less these days, especially Lemtrada, which is a very strong medication. And it's probably the closest one that we have to bone marrow transplant, as it's really kind of reset the immune system, but at the expense of risk of some significant side effects, including markedly increased infectious risk and some autoimmune conditions. And natalizumab or Tysabri is a great medication in general, but with a risk of PML, so that I'll also touch upon in a few slides. So it's really important to kind of have very careful monitoring for that medication in particular. And then actually, this is now kind of going to PML. So as I mentioned, just to go for a second on prior slides, so Tysabri is really the most important one when talking about PML, although it is also associated with multiple other medications, but just to much lower frequency than with Tysabri in particular. So, and then PML, that stands for progressive multifocal leukoencephalopathy, is essentially infectious disease of central nervous system caused by virus called JC virus. It is widely prevalent in general population, like in about half, or a little bit above half of population is present. And as long as immune system is adequate, it is completely indolent. It can be present usually in lymph nodes or sometimes in kidneys and really be completely harmless. The problem is when there is some defect or problem with the immune system, such as, for example, back in the day with AIDS, when lymphocytes were not available and when a reactivation of this virus was catastrophic, or in this particular situation would be when it is kind of we essentially artificially manipulate the immune system in order to minimize harmful effect to the brain and spinal cord. But this virus in that setting can needs to mutate, then can squeeze essentially into the brain and spinal cord and cause inflammation and further damage. It's usually presents subacutely over weeks, again varying on the area involved, but some of the symptoms that can be more cognitive, weakness, rather affecting part of the body, left or right, and sometimes peripheral vision loss, and then it can look something like this on MRI. So if you remember from kind of more typical brain MRI or spinal cord MRI lesion, those are distinct, those are kind of very multiple, very specifically kind of characterized and distinct from one another. Those are much bigger, fluffy, sometimes called geographical lesions, so with irregular borders. And then also occurring or a little bit slower than with typical MS relapse. So this is really important to kind of have in mind, and even more because it can be fatal. Some data show that with Tysabri it can be about like 30% fatal, but and people who survive also can have some more significant neurological deficit. But the good thing is that there are ways how we can monitor that, and one of them is these antibodies to the JC virus that we can monitor. And usually, even if these antibodies become positive, risk to get PML is not imminent. It grows over if the medication is considered over upcoming years. So yeah, with careful monitoring of these antibodies, we can definitely kind of prescribe this medication much more safely. With another medications, this still can occur. The risk factors are less clear, but the really risk is extremely small. So we're usually talking about few cases or per few 100,000 of people. And with Gilenya, which is a pill, it's a little bit more. It's about 50, 60 cases so far. But yeah, Tysabri is really the one that we need to be most careful about with PML in particular. Now, how to decide about these treatment option? That's falls into kind of many components. One of them, for example, is age. Again, it will be very different approach if somebody is, let's say, is younger and is planning to have a children in the upcoming years, or if we're talking about adolescent or a little bit older person who's diagnosed with MS, and then depending on other kind of comorbidities, state of disease. So I didn't mention, so for primary progressive MS, so for that phenotype with only gradually worsening symptoms since the beginning, only ocrelizumab or Ocrevus infusion is approved. While with these other two phenotypes, we have many more available options, essentially all that I previously mentioned. Also, depending on the specific side effects of each of them, it'll be important to consider for a kind of particular patient. And then there are also some other things. Let's say if somebody is contemplating infusions, depending how far is infusion center, what fits better somebody's lifestyle. Insurance coverage, of course, can be a factor, especially if there's denial. And then ultimately, after a detailed discussion, it's of course it's a patient preference in the end, and what someone feels more comfortable with taking it. Why are people reluctant, or what are some barriers to treat MS? I think this, the first one, absence of symptoms. It's a very important one, especially in young people or younger who feel well, who have a relapse and then recover completely. And then it's really important to emphasize again that the whole purpose of taking disease modifying therapy is prophylaxis. So to minimize risk, and that someone will be definitely in a much higher risk if not taking these medication. And then there's some other kind of cost of medication can be a factor, especially if copay is high, and then side effects, of course, the same within any other medication in general. And then fears of needles can be one of them. Again, if that is the kind of mode of administration that is considered to be taken when choosing disease-modifying therapy for MS. In terms of wellness, so what can be done and kind of I would say the best effects on MS treatment can be achieved if there is kind of that collaborative kind of treatment from us as a healthcare professionals, and then when patients try to optimize their health the best possible. There are some of the also here lifestyle kind of or modifications that are not infrequently neglected and are definitely important, for such as diets. So there's really no specific diet that shows in kind of clinical rigorous trials that is more efficacious than another one. But I mean, more like healthy diets, kind of low fat, sodium, high fiber diets, and regular kind of also not skipping meals, avoiding some bad habits such as smoking or heavier alcohol drinking. In terms of supplements, multivitamins are always a good thing to take in addition to vitamin D that I mentioned earlier in the talk. Alpha lipoic acids are data are somewhat kind of non-conclusive to be helpful, but I mean, it also can be taken. Exercise is very important, and it cannot be overemphasized. So, I mean, any type of regular physical activity, and then integrated care, some kind of massage therapy, acupuncture. Some people find like mindful meditation helpful. So all of these are some of the things. And then beyond this, also to control other just general health hazards and make sure that blood pressure is under good control. There's no anemia, that's either any thyroid problems or other just kind of general medical issues, if present, to be controlled. They can all help kind of optimizing overall health and also ameliorate some of the neurological symptoms as well. Now, what is on the horizon? So in terms of there are few layers kind of mentioned here. Remyelinating agents is a really needed topic, and there are multiple attempts so far, not very successful, although still kind of we're trying to get some that will be kind of efficacious and reliable. In terms of stem cell transplant, so there's still trials in this. It's not FDA approved yet, but I mean, kind of over the years, kind of I would say we're getting better and better in terms of minimizing risks, and we'll see if this can be also kind of reach the level to be one of the FDA approved or standard of care treatment. Not yet there. In terms of biomarkers, especially neurofilament is one that has been more taken into account in recent years, and will still it's pretty promising, but still trying to find the right spot for it. And then, I mean, really medications that are getting on the markets and that can be researched. For example, there is new class BTK inhibitors. There are a few of them that unfortunately did not show efficacy, although we have high hope. But one of them, tolebrutinib, data we're just presenting in ECTRIMS in European MS conference, showing that actually it can be helpful in kind of more progressive form of MS and slow down disease progression. So that's exciting. And we'll see. It will go through the process of insurance approval if it will clear FDA. There's some other treatment options. I put frexalimab, that kind of clinical trials actually for both progressive and relapsing MS that we are doing at our institution, and it's we're currently doing clinical trials in that. So yeah, and we're excited about that one as it has kind of completely different mechanism of effect, so not previously tried in MS. And then really ideal goal is to personalize treatment and kind of have really even better kind of found biomarkers, how we can personalized treatment for every patient. I think still, as of now, MRI is the best biomarker that we have. And then this is our team. So with the Providence MS Center, 5 physicians and 1 nurse practitioner, and also with an extensive research program. And those are some additional resources that can be helpful with, especially kind of, I think National MS Society is a great website to kind of put various additional kind of resources and information about MS, as well as other links listed here. Okay, I will conclude here, and thank you for your attention.